Thank you very much, Shima. Good morning, everybody. So it's an absolute privilege and pleasure to be here, and thank you to the organisers for asking me to speak. So I'm going to talk about brain health in women living with HIV. And I'm going to start with a general update on brain health in people with HIV, and then really focus on considerations for women and finish on some management considerations. Now, whenever I do a talk on brain health, people say to me, this is so boring, nothing's changed for 20 years, okay? But I hope I convince you all over the next 20 minutes that actually this is a field that's moving and things are changing. So, firstly, an update on brain health. I'm going to talk about two things here. Firstly, defining brain health and defining cognitive impairment in people with HIV, and then move on to our more modern understanding of risk factors for impaired brain health, and then we'll move on to the important relevance of many of these risk factors for women living with HIV. So firstly, defining cognitive impairment. This has been an absolute mess. It's been a complete disaster, to be honest. So what I want to look at is how we got into this mess and how we can get out of it. Okay, so 30 years ago, before we had antiretroviral therapy, things were actually quite simple because people without antiretroviral therapy, some people got AIDS dementia complex, and this was easy, relatively easy to categorise. But with the advent of antiretroviral therapy, it was quickly recognised that most people on antiretroviral therapy do not get severe HIV-related brain injury. But it was noted that some people had more minor cognitive disorders, and there was a working group over 20 years ago which tried to categorise this. Now, this was all with the best intention, okay? People were looking at how we could recategorise brain health in people with HIV with the advent of antiretroviral therapy. And I have no criticism on this group because 20 years ago they did a nice job. It's just that this job is not fit for purpose. And they came up with this job called the HAND criteria, HIV-associated neurocognitive disorders. Now, the problem with the HAND criteria is there's several problems. One of the problems is there's a group that don't have symptoms, and they still meet this category. And another major problem is the mathematics, the statistics of it, that everything, or many of our parameters in life are a bell-shaped curve, our weight, our height, etc. But the criteria is based on a bell-shaped curve and categorising people one standard deviation, so 16% of the population who don't meet this. And when you've got lots of cognitive domains, you end up categorising loads of individuals as having cognitive impairment. Now, I mentioned in the questions earlier, in the UK, myself, Caroline Sabin and many others run an ageing cohort on looking at the effects of ageing with HIV in the UK and Ireland. These are our cognitive results from almost 10 years ago, the baseline visit. And when we look at the average cognitive score in people with and people without HIV, you can see that the numbers at the bottom, in people who don't have HIV, it's 50.8, that's a T-score, and people with HIV, it's 48.5. It's pretty similar. And if you ask a neuropsychologist what would be a clinically relevant difference in a T-score, it would be a 5-point difference. So essentially, there's very little difference here. And importantly, many of the people with HIV in this cohort are people that have been living with HIV for a long time, so they have had legacy effects from not having antiretroviral therapy and other AIDS illnesses in the past. And even with those legacy effects, we see quite similar results. What you can see is that some of the individuals with HIV, the deviation goes down, so there are some individuals who are performing slightly more poorly. So these results are pretty reassuring that in most people with HIV, brain health is very, very good. Now, in South Africa, Sam Nightingale in Cape Town has looked at defining cognitive impairment using lots and lots of different definitions. And when you use this is a cohort of people living with HIV, undergoing cognitive testing, and then using different mathematical definitions. And you can classify from 20 up to 97% of people having cognitive impairment just by the definitions being used. And you'll see that the HAND criteria, the FRCP criteria, sit in here. So these definitions really aren't helpful. And what's more important is these definitions are detrimental. Okay, we've had challenges in the UK. We've worked with the UK Civil Aviation Authority because they weren't allowing people living with HIV who were pilots to have unrestricted licenses because of concerns of cognitive impairment. In South Africa, this is a relatively recent publication questioning whether people with HIV should be allowed to be long-haul drivers because of cognitive performance. And I've just shown you data that cognitive performance generally hardly differs in people with and without HIV. So one of the first principles in medicine, which is thousands of years old, is first, do no harm. I don't think we can say that these criteria are not doing harm. So we have thankfully got a new consensus definition called the HABI criteria. Now, this is a first step in moving away from the HAND criteria, but this talks about brain injury in people with HIV, whether it's related to HIV, whether it's related to other things, and whether it's active or whether it's inactive. So it's a much more clinical definition. Okay, what about some of our modern understanding on risk factors? Well, the first thing, and I've mentioned already, there can be legacy effects. So if we go back 30 years, we didn't have antiretroviral therapy. People had untreated HIV. The initial antiretroviral therapies were not as good as the therapies we have nowadays. So one of the questions is, if we start antiretroviral therapy very early in HIV, and we start with modern antiretroviral therapy, can we mitigate the effects on brain health that we might have seen historically? And these are data from a Thai cohort of individuals who are undergoing HIV, are at high risk of HIV acquisition and undergoing HIV testing frequently, and are, if someone does test positive, they start antiretroviral therapy very quickly. The median time to starting antiretroviral therapy in this cohort is 15 days after likely acquisition of HIV. And the message here is that cognitive trajectories return to what would be expected at baseline. The green line are the people that have good cognitive function at the start. The blue line are the individuals who have slightly poorer cognitive function at the start, but everything is returning to the norm. Now, there's a lot of studies suggesting that the earlier initiation of antiretroviral therapy and more modern therapy can mitigate some of the historical effects we've seen. Now, this is a really important study which I want to talk about. It's called the CONNECT study, and it comes from Cape Town in South Africa. And this looks at cognitive health in people with HIV and cognitive health in people who don't have HIV. And the people with HIV, the cognitive assessment is prior to the rollout switch in antiretroviral therapy. So at baseline, everyone was on efavirenz-based therapy, and at follow-up, everybody had switched over to dolutegravir-based antiretroviral therapy. So on the left, you can see that the baseline. The orange bars are the people who don't have HIV, and the blue bars are the people who do have HIV. You can see at baseline, higher numbers of people with HIV would meet some definition of cognitive impairment, and you can see on the left-hand side the outliers is more in people with HIV. But what's really important and really reassuring is that at follow-up, the results are very, very similar. Now, these data have two important implications. Firstly, people with HIV have very similar cognitive function to people who don't have HIV. And secondly, we see a reversal of the cognitive effects on efavirenz, and we're not seeing any signal that dolutegravir may have any effect on cognitive function, given that the people with HIV are performing very similarly to the people who don't have HIV. People then ask, well, what happens with aging? Are the trajectories of aging similar in people who do and don't have HIV? Now, the data here are conflicting, and different studies have shown different results. These are data from one of our studies in Europe. This is from the Dutch cohort and our UK cohort, looking at longitudinal trajectories of brain health. And in blue is the people without HIV, and red is the people with HIV. At baseline, you can see the cognitive performance is a tiny bit lower. Remember, the scale here is magnified up, so this difference is quite small. But the trajectory over time is the same, and the same for changes in brain imaging parameters. Now, there's a San Francisco cohort which shows the exact opposite of this. It shows that people with HIV do have a higher trajectory of aging, but the controls they have included are 70-year-old marathon runners. Now, most of us are not 70-year-old marathon runners, whereas our controls are very similar to the people who are living with HIV. Now, comorbidities are an important impact on brain health. And we talk about individual comorbidities, but we can also think about clusters of comorbidities. And these are some clustering work from the POPI cohort, which have been validated in many other cohorts. So we see a cardiovascular cluster, which can clearly impact on brain health. Importantly, we also see this mental health cluster, which can impact on brain health. So mental health we know that different mental health conditions are highly prevalent in people living with HIV. These are data from Positive Voices, a UK study. And what we see here is that mental health conditions are prevalent in people with HIV, but prevalent across all age groups, all genders, and all ethnic groups. So there's nothing you can tease out saying, well, if you're a bit older, you don't need to worry about mental health, or if you're female versus male. We're seeing it across the entire population. Another consideration for brain health, which is really important, which I think has been under-recognised, is concomitant medication, and I'll come to that in just a second. Now, everything I've been talking about so far has been very positive, and I'm very positive about brain health in people with HIV. We all age, and as we age, every end organ function does deteriorate. Okay, so our bone mineral density declines as we get older, our kidney function declines as we get older, so does our concentration. And here you've got different maps of aging. I suppose one of the questions is, if there is a slight legacy effect in people that have been living with HIV for a long time, could they cross a threshold slightly earlier, a clinical threshold, than a population that don't have this legacy effect? And I think that's something that we still don't know. Now, moving on to concomitant medication, there's been quite a lot of work looking at the effects of anticholinergic medication associated with aging phenotypes, with frailty, but also with cognitive health. These are data from the Swiss HIV cohort describing that people on concomitant medication, which can be classified as anticholinergics, may have higher rates of symptoms of poor cognitive health. Okay, so that's the background. Let's put all this into context for women. Now, the most powerful study looking at cognitive health in women living with HIV is the WISE cohort in the US. And several years ago, they published data very similar to the data I showed you from POPI. That's not on this slide. And that is that women living with HIV in the WISE cohort had very similar cognitive function to women who living without HIV. So again, reassuring data. And the WISE cohort is like our POPI cohort, is a cohort where a lot of the women have been living with HIV for a long time. There's some really nice work here on this slide looking at cognitive profiles in women with and without HIV. And we do see some slight, subtle differences between the cognitive profiles. I always look at this slide and try to sort of digest it. But if you like, I think what we're seeing on the top are the women living with HIV, And some of the profiles, the processing and some of the speed domains may be slightly more frequently observed in the people and the women living with HIV. So, for consideration for women, I want to think about stigma, depression and social determinants of health, and then move back on to the ageing, comorbidities, and Shima, don't worry, I will not leave this stage without talking about the menopause. Okay. Now, this meeting, I was just looking at the agenda when I was putting these slides together. There's loads of aspects, and these are some of the posters that I pulled out from the meeting on stigma, depression and social determinants of health. These aren't specifically related to cognitive health, but these parameters are going to affect brain health. We're seeing data that on the effects and stigma in women living with HIV on mental health, and this is all going to affect cognitive health. Stigma is something that has been, I think, under-recognised in the field of brain health and cognitive health. This is a study looking at the association between stigma indices and 2-year decline in cognitive function, and 50% of this cohort were living with HIV. And the black lines are the individuals which improved cognitive function, and the red lines are the deterioration in cognitive function. And you can see as you go over to the quartile 4, there's these are the individuals with a higher stigma index. They're more likely to have a deterioration in cognitive health. There has been data from the WISE cohort, so in women living with HIV, looking at also looking longitudinally on the impact of stigma on cognitive health, showing that higher stigma indices are associated with poorer cognitive trajectories. So this really raises the aspect on, should we, when we're screening for cognitive health and thinking about cognitive health, should we be thinking about stigma, and should we be thinking about interventions to help improve stigma? This is also thinking about social determinants of cognitive health. This is a South African study, one of the few studies where men and women are included, but it's overrepresented by women, so 75% of the cohort are women. And describing here that the social determinants of health are really, really important. I know it's a busy table, but I'll just talk through it. It's that the social determinants of health are really one of the major drivers of poor cognitive health in this cohort. So what's about ageing, comorbidities and the menopause? Well, I mentioned polypharmacy before. I mentioned also that the WISE cohort have done everything when it comes to looking at cognitive health in women living with HIV. But these are data on the impact on polypharmacy on cognitive health in women living with HIV, both the entire cohort and virally suppressed women living with HIV. And then you have the burden of polypharmacy, a medium burden or a high burden. And you can see as you go down different cognitive domains, the higher burden of polypharmacy in women living with HIV is associated with poorer cognitive function. Now, Shima, I was really excited when I was doing this talk, because I thought I'm going to look up all the data on menopause, women living with HIV, and cognitive health. And I was really shocked and disappointed to find that there's one publication. Now, correct me if I'm wrong, but I think this is the only data on the impact on menopausal status and cognitive health in women with and without HIV. So this is a research gap, it's a data gap, and it's something that we need to think about. So in this study, we do see that menopausal status, as we know from other populations, is associated with brain function. I think what we're seeing reassuringly here is that the impact on menopausal status is very similar in people with and without HIV. So we do see a difference. We see higher cognitive performance in people who are premenopausal rather than those who are earlier postmenopausal, but we're not seeing a difference between people with and without, women with and without HIV. However, I do believe this, correct me if I'm wrong, if anyone knows other data, but I think this is the only study, so it's something we do need to look at. Okay, I have 4 seconds. Management considerations. Okay, so I've given you an update on brain health in people with HIV. I hope we're moving to a more useful definition. Early antiretroviral therapy may help mitigate effects on brain health, and comorbidities and concomitant medication are important. Important considerations for women. I think the comorbidities, the social determinants of health, the stigma, are important, and maybe even more important for women living with HIV. We know very little about the impact on the menopause. Now, management. I was going to put a slide up on the EACTS guidelines or the British guidelines. We all come from different countries, but I think the guidelines are all lacking, if you like. When we talk about screening for cognitive health, we recognise depression, but people aren't recognising we need to be thinking about sleep, as we heard earlier. We need to be thinking about stigma. We need to be thinking about other determinants of brain health, and that's an area where I think we can all be pushing. So I hope that's given some food for thought. Thank you very much for asking me. And for those who are interested in HIV in the brain, there's some fantastic other meetings. We've just had our UK meeting. There's a Barcelona meeting next month, a neuropsychiatry meeting, and there's an amazing Italian meeting towards the end of the year. Thank you.